I'd like to introduce our last group of speakers to try and give us a little bit of an update in urology. I'd like Raj to start the discussion, followed up by Mike Henley, who's a consultant urologist at Derby.
Just a couple of minutes about microscopic hematuria or non-visible hematuria. I did have a PowerPoint, but we're going to stick with Mike's. We've come up with a pathway for non-visible hematuria, which Mike will touch on as well. You've all got a copy on your table, which if you've got any comments or feedback on, I'd be quite glad to hear. We did an audit of 2-week wait referrals in urology, and I was surprised about 55-60% of all referrals are going to urology are 2-week waits. And something the consultants mentioned, the microscopic hematuria ones, could be worked on in terms of the need to refer them up to the hospital. Now, just a couple of main points. I won't dwell on it too much, but on the second box, the second blue box, symptomatic non-visible hematuria, that's not a UTI symptom. So if you've got a UTI, you don't actually go through the pathway. Symptomatic means if you've got voiding symptoms, got hesitancy, so not UTI symptoms, but symptoms suggestive of kind of bladder problems in the absence of UTI. The main thing and the main variation in referrals was the dipstick positive. So the MSUs, we know if they're more than 18 plus on the red cells, are an indicator of blood, but a more accurate indicator is actually a dipstick. And something we're quite keen to promote is the 2 out of 3 campaign. So the biggest variation in the referrals were, there were some referrals that are coming in with just 1 plus of blood on one occasion. For it to be a positive result and make a referral, it's 2 out of 3 positive at weekly intervals. If you've got a UTI, treat it and then check it 3 times after that. If it's still positive, that's when you refer them up. And it's 1 plus blood, not just trace. The other main thing, and the last thing I was going to say is as per the pathway, if patients less than 40 don't need to be referred up. So there are some annual monitoring guidelines. So if you're happy with the pathway, then you don't have to refer them up. You can actually just follow the pathway and do as it says at the end. That's about it for me, really. I'll pass you over to Mike, who will touch on this with some case examples as well.
Lovely, thanks very much. I know it's quite late in the afternoon, but I might make it slightly interactive. I'm sorry about that. Whilst I'm giving the talk, I've got a number of topics which I'm going to present and talk about today. But if you could think about other urological topics and questions that you've got that you'd like to ask me about patient examples or case scenarios or whatever, I'll be happy to answer those if we get to the end and you've still got any will to live, all right? So I'll try not to make it too miserable. So the first thing I thought we would start off with is hematuria, and what I thought I'd do is just to get us warmed up, just to get us going, I'm going to give you a case example and I want you just to tell me how you're going to manage the patient. So there's a chap, 65, comes along and he says to you, he's seen some blood in his urine, that's his only symptom. What are you going to do?
2 weeks referral.
Fantastic. Very straightforward, 2-week wait referral. Symptomatic non-visible hematuria, you know we all say dips. I used to spend hours with medical students saying, come on then, you're so clever, what's the definition of hematuria? And they'd say, oh, I don't know, I'm crikey, is it blood in the urine? Traditionally it was whole red blood cells in the urine. But the trouble with that is you take a sample in general practice, patient comes in, one of those lovely little pots, maybe in a film canister, put it into your fridge in general practice, whatever a film canister is, I know it's 2014. You put it in your fridge, it goes off to the lab, often you've dipped it in the practice and it's positive, and then lo and behold the MSU comes back and it says negative. What the hell's gone on there? Why is that? They've just lied, haven't they? So therefore we miss patients that may have significant pathology. So now it is just dip positive. Anything more than 1 plus is hematuria. Yeah, anything more than 1 plus on dip is hematuria. It doesn't matter if it's lysed, if it's not lysed, it's just hematuria. But what we ought to do is...
Sorry, more than 1 plus or 1 plus?
1 plus or above, yeah. It ought to be repeated if they're asymptomatic. So if we've got a patient here who's, say, let's say, just to really make it hard, 38, painful bladder, male, 1 plus of blood on dipstick, twice.
What would be MSU?
MSU comes back as negative. So I love guidelines. So they're 38, 1+ on dipstick twice, painful bladder, male.
The DM screen.
No, you need to send them to urology. Send them to urology. 38, if it was 38, asymptomatic, dip hematuria, yeah, ×2, not interested. Tell him stop playing rugby, water polo, stop jogging, whatever it is, yeah. That's the distinction. If they're symptomatic, bladder pain, something like that, and they're under 40, we need to see them. If they're asymptomatic, and it's an incidental finding, we're not interested in urology, okay? This is a bit small, but this is the asymptomatic ones. Some of what do you need to keep an eye on? If they're asymptomatic and it's persistent hematuria, you need to keep an eye on abnormal protein. So protein creatinine ratio, keep an eye on that annually. Watch out for renal function. Is their EGFR declining? Is their blood pressure rising? All of those things suggest a renal referral.